I was really trying to get a sense of what's going on with Med-Surg and the RNs there. And I'm taking advantage of this survey from HRSA, who every 4 years, they send a survey out to 25,000 RNs, 25,000 NPs, and ask a huge amount of really helpful questions, a lot of subjective questions, satisfaction types of questions. So I polled these 4 groups of RNs in the hospital, 2018 and 2022. I kind of wanted to make some comparisons of relatively large, stable groups who are well-defined to just see how they differ from each other. So that's going to be this next section. Okay, first of all, something that I suspected from what people were saying, it's harder to get new grads into Med-Surg. A lot of folks, it doesn't seem sexy or exciting and so on. And that seems to be true when you think of between 2018 and 2022, do you see a surge of younger RNs into these areas? Yes, for all of the other areas, but not for Med-Surg. Okay, everything else is kind of growing younger in a sense. They're getting an inflow of some of the new folks. So that was one thing that was interesting. This was really dramatic to me. Is part of this is the pandemic, but this basic question of how satisfied are you with your current position? 2018 is on the left, and I'm comparing these 4 groups, and they're all fairly similar. And the picture really changes. By 2022, first of all those red bars go down. Satisfaction everywhere just like dropped off a cliff between 2018 and 2022. But it did that more so for the Med-Surg group. You can see now they have the highest rate of extremely dissatisfied. It's not a lot, but it's a lot more than every other unit. And they have the lowest rate of saying, I'm extremely satisfied. Whereas again, in 2018, they were kind of the same as everybody else. So it seems like things got worse for them. So that's satisfaction. Then they ask a whole set of questions, which are really great, about what might be behind these differences in satisfaction. So the way this question is worded is, what are some things that make you consider leaving your current position, or your, not nursing altogether, but why would you leave your current position? And I'm picking out the ones where the Med-Surg RNs said that more so than the other folks. What are their main problems, pain points? And they said, my patient population, maybe that's related to patients with mental health conditions. They didn't get that granular. I have a stressful work environment. I have high-risk working conditions. These are why they are saying, I'm considering leaving more than RNs in these other units. And on the next slide, I'm just going to show all the options arrayed. Towards the top is where the Med-Surg RN said, this is worse for me. The population, the work environment, high risk, and so on, a career change. On the bottom is the one thing where they said, this is actually better for me. And that's scheduling convenient hours, interestingly. So they're not saying that is more of a problem for me than anyone else. That actually seems to be okay. Well, on the flip side, just a few more. They asked, what are some things that you like about your job, or that would make you want to stay? And I'm pointing out the ones where Med-Surg RNs were less likely to say, I like this, than the other folks. Liking the job, okay, that's the basic one. Pretty low. Experience at my site, a sense of community with peers. Maybe that gets back to some of the, the team that you were just talking about. And here's again the full set of those questions. So the things on the top were where they said, these are positive things, but I'm not feeling it. And then on the bottom, cost of living was the only thing that they said they felt better about than the other folks. Could just be about where you are. Yeah.
I just wonder for the group, we've talked about virtual care models in the past and ongoing. Has that helped in the Med-Surg units to retain staff and improve some of these conditions? So I'm just curious for the group if anyone has experience with that or track that data.
Yeah, we've implemented, and I'm going to talk about it a little bit later, but yeah, it has helped us in Med-Surg. It's all aimed at Med-Surg, and so we've gotten very positive feedback from the nurses.
One of the things I'm curious about too, and it's probably not reflected in the data, but part of what I hear from the Med-Surg nurses is their lack of respect from the critical care nurses, the transport nurses, the whatever. So we have an internal problem within our profession too, recognizing the value and work that the med-surg nurses do. So I don't, maybe that's a conversation over lunch or something, but.
It reminds me of primary care physicians versus
Exactly,
specialists.
versus a surgeon.
Yeah, that's a hard problem.
Well, I think we have to think about how, David, you said it make med-surg sexy again, but is it? I don't know if the word you use.
That's hard.
I like it.
Yeah,
Bringing
but
sexy back.
Med-surg needs to be the foundation and the place where we perform innovation, right?
Yeah.
Being a med-surg nurse means that I have wraparound alternative care model services, whether it be virtual care, whether it be AI that's being integrated. That needs to be where we start with those types of initiatives so that it attracts the talent to stay there. It's not paying med-surg nurses more than critical care nurses. It's not giving them higher sign-on bonuses. They're going to leave regardless. It's making the environment of care more supportive, more innovative, more exciting to be a med-surg nurse again. And I think some of our colleagues obviously are doing that. So
I totally agree with that, and how we rebrand that is critically important. Working in an organization where we have quaternary care, it's your cardiac, it's your neonatology. Those are the niche where most of the revenue is generated. And our nursing teams are sophisticated enough now to understand that they are driving the revenue. And oftentimes they feel as if we are the poor med-surg units that don't have a lot of zeros behind our budget. That mean if there's opportunities for development, the money is there in those quaternary niche services and not in med-surg. So how do we rebrand that, to your point, where this is where the innovation happens? Really, I would say the miners that build the infrastructure for everything else that we have is really housed in our med-surg areas. So how do we rebrand that?
One of the things that we did, we put everyone in a service line. So everyone is your specialty, your cardiac. So if you're tele, you're in the cardiac service line. Trauma, you're in, burn, you're in the trauma service line. So that's how we are elevating. We're not there yet, but we're elevating. So because that became a thing, we're just med-surg. And of course you had to go, you're not just anything. You are the acute care. We don't even call them med-surg anymore. We call them acute care nurses. You're the acute care nurses. So either you're on one of the service lines, and for our community hospitals, that's not big enough to have, you're the acute care nurse. And one of the things that we also did, tying it with patient experience, when the ICU send a patient to the acute care floors, the leader, nurse manager, A&M, or educator must come and see that patient on the floor within 24 hours or so to ensure that. And with that, they have been saying, oh my God, how does these poor med-surg nurses do this? Right? When they see the amount of work. So it's that respect is because they realize, hey, I can hang the strip and do all this, but I could not care for 5 or 6 patients within 12 hours and give them, great care. So we have to come up with different strategies of how do we bridge that gap, because it's a true gap.
Do most people rotate through med-surg before going to ICU or some other specialty unit? No, not necessarily.
They will now at Jackson starting very soon. Yeah, to develop that respect, yeah.
That's great. Okay. Yeah.
More of just a provocative statement here. Those who know me know I'll do that. So
Sure.
what's fascinating by this right here to me is that cost of living and loan repayment, all the things that are being used right now for med-surg is the thing they don't care. It's not what keeps them there.
Yeah.
So the provocative thought is,
Yeah.
I was literally just texting this to Andrew.
It's more than that.
Like, well, why do we keep doing market adjustments and adjusting their base pay when they're sitting here telling us, like, we don't care, just fix the staffing? I just find that fascinating.
Yeah.
That they would rather not have potentially a $4 an hour raise and rather you take for the size of our system, I don't know, $20 million that creates, and fix the actual problem that they're experiencing. So just, again, provocative thought there, but.
It's hard, but it's worth it. Sounds
Right.
like.
I think it's a good point. I think something that can trip that up is that, especially as I see generational differences, the things we're doing, including $4 an hour market adjustments, are table stakes for them to be in this opportunity. And I think that's when you see this stuff, like you gotta be careful to think, okay, if it's lower, maybe we don't have to do as much, it's not as sensitive. But as soon as you take your finger off that, it will pop right up, right? I just think we've come out of the pandemic, maybe. People have been able to breathe and put market adjustments. And, you know, that's how it impacts contract laborers down. And so we've gotten to a good place. Just, you know, as an HR guy, I'd say, if you come off that at all, it'll come right back.
Not suggesting fully.
Yeah, no. I'm just, yeah, no, I
Depends on your
understood.
market.
I understood what you're saying. I
competitiveness,
mean,
lots of variables there.
you have, I'll use your example, you got $20 million to spend. Make sure you're putting it in all the right places,
That's
not
right.
in one place.
That's right.
But if you don't take care of this place, it will pop right back up.
Absolutely.